Hey everyone, and welcome to today's Explainer. If you're a focused learner looking to really wrap your head around the clinical pathology of the human body's ultimate biological engine, well, you're in exactly the right place. Today, we're not just looking at the heart as a standard organ, we're looking at it as a complex, tireless machine. And to do this justice, we're drawing directly from a seriously structured source, Harsh Mohan's 7th edition textbook of pathology. We're going to dive into how this textbook masterfully breaks down cardiac pathology right there in Chapter 14.
Okay, let's dive right into this. Chapter 14 spans exactly 43 pages. Literally from page 397 to page 440. This text gives us a hyper-focused, incredibly meticulous catalog of every single thing that can go wrong with this perfect machine. Just think about that for a second. 43 pages strictly dedicated to the mechanical failures, the structural flaws, and the biological breakdowns of the heart. It's an absolute mountain of information.
But seeing all that, it raises a pretty fascinating question. How does a pathologist actually categorize a broken heart? If we step into that medical detective mindset for a minute, we realize pretty quickly that we can't just get bogged down in the sea of dense medical jargon. We need a solid framework, right? We have to ask how these failures are grouped mechanically. Like, how do we actually make sense of the chaos when the engine starts to stutter?
Well, here is the roadmap for our explainer today as we mechanically break down these failures. 1. Blueprint errors covering congenital disease. 2. Blocked pipes, focusing on ischemic disease. 3. Rheumatic and valvular diseases. And finally, number 4, the failing pump, basically heart failure. So, let's kick things off with Section 1, Blueprint errors, or congenital disease.
What's really interesting about this is how congenital heart disease cleanly divides into 3 very distinct mechanical categories. First up, we've got malpositions, where things are simply built in the wrong place from the start. Second are shunts, which are essentially fluid leaks that cause cyanotic conditions. This literally starves the body of oxygen, turning tissues blue. And third, obstructions. These are structural blockages built right into the system from day one. It's actually a brilliant way to understand birth defects, not as random occurrences, but as specific architectural errors. Wrong place, wrong routing, or blocked pathways.
Moving right along to Section 2, blocked pipes, which covers ischemic disease.
Now, before we look at the fallout, we really need to define the problem itself. The absolutely crucial point here is understanding ischemia. It's defined as a restriction in blood supply to tissues, which causes a critical shortage of oxygen. Essentially, this is a severe plumbing issue. The pipes that feed the heart get blocked, which effectively cuts off the fuel supply to the engine itself. And that brings us to a very serious, very urgent question. What are the actual effects of myocardial ischemia? When the heart muscle, the myocardium, is starved of its vital blood supply, the stakes are incredibly high. It triggers this massive cascade of mechanical and biological fallout when the engine tries to run without its essential fuel. Frankly, it is one of the most critical mechanical failures the human body can ever experience.
All right, that takes us to Section 3, rheumatic and valvular diseases.
For this category, it all starts with an initial event, rheumatic fever. But you have to remember, this fever is really just the catalyst. It paves the way for chronic rheumatic heart disease, which then directly leads to valvular diseases and deformities. Think of the valves like the doors of the heart. They're supposed to snap shut to keep blood moving in one direction. But because of this disease, those doors become totally warped and stiff. And this brilliantly illustrates how pathologists meticulously classify these hinge failures. On one side, we have rheumatic endocarditis, but on the other, we've got the non-rheumatic culprits. This includes atypical verrucous, also known as Libman sex, which we often see in autoimmune diseases like lupus. Then there's non-bacterial thrombotic or merantic endocarditis. And finally, infective or bacterial endocarditis. It's just a perfect structural breakdown of exactly what is attacking the inner lining and the valves of the heart.
Which brings us to our final section, Section 4, the failing pump, better known as heart failure.
Before attempting any kind of fixes, clinical pathology anchors on 2 fundamental concepts here. First up is the etiology, meaning the exact root causes of why the pump is failing in the first place. And second, the specific types of heart failure. You see, it's absolutely vital to classify exactly how the pump is failing before we even start looking at how the body attempts a desperate fix.
And that desperate fix? Well, it relies on what we call compensatory mechanisms. When the pump is failing, the heart essentially tries to fix itself using one of 2 methods.
It either bulks up its muscle mass, which we call cardiac hypertrophy, in an attempt to force more power into the system, or it stretches out its chambers, known as dilatation, in a bid to hold and move a larger volume of blood. It's a completely fascinating, yet ultimately unsustainable, mechanical trade-off just to keep the engine running.
So why does all of this actually matter? What should you take away from this? Basically, grouping these diseases mechanically is the ultimate blueprint for clinical survival. Understanding these classifications, whether it's a congenital shunt, an ischemic blockage, a rheumatic valve deformity, or hypertrophic compensation, that dictates exactly how doctors identify, diagnose, and treat the failing machine. Without this highly organized structure, clinical pathology would honestly just be a list of random symptoms.
Which leaves us with this final, truly remarkable question to ponder. If the human heart is an engine that constantly tries to compensate for its own structural failures, bulking up, stretching out, working around blocked pipes and deformed valves, what are its ultimate limits? It really makes you marvel at the absolute resilience of the human body, doesn't it? I hope this leaves you eager to explore even more of the fascinating world of clinical pathology. Thank you so much for joining me in this explainer today. Keep questioning, keep learning, and I'll see you next time.